Hello everyone, and welcome to our Homes for Cathy workshop, increasing integration between homelessness and health, between housing and health to tackle homelessness. Bit of a mouthful, and it's great to see so many of you here today, not only from housing associations but also from local authorities and charities, which I think is testament to the fact that we all want to work together in partnership to tackle homelessness. As many of you will know, Homes for Cathy has 9 commitments, and members pledge to work to all these commitments. One of them is, the first one in fact, is to work in partnership with our local authorities to plan and execute homelessness strategies. So the theme of working in partnership, I guess, is why we're here today, because I think, you know, for as many of you probably have read, many reforms going on in health at the moment, health and social care, which really there's a really an onus on increased integration between health and social care and local government to try and tackle health inequalities. And obviously homelessness people do face a lot of health inequalities. So I think that in turn obviously presents opportunities for local authorities to look at different service delivery opportunities, and also to work with their housing association partners to potentially deliver these. So that's something we will touch on today in our workshop, and I'm very fortunate to be able to welcome Andrew Van Doorn. If you don't mind, if you could mute. If you're not already on mute, that would be great because there's a bit of interference. Thank you. So we're very fortunate today to have Andrew Van Doorn from HACT. HACT is a specialist housing charity that works with housing providers to create transformational change. And Andrew is a bit of an expert in this area because he's also a non-exec director of a large NHS trust. Hopefully he can answer any questions that you have, and we're going to run this as quite an interactive session. So Andrew will speak briefly about some of the changes that are currently going on, touch upon some of those opportunities that these might present for us in housing and in local authorities, and then he's going to speak for about 25 minutes. And then we're going to open the floor to questions and answers. So please feel free to put these in the chat box or raise your hand. If you hover over the bottom of the reactions tab, you can raise your hand and we'll aim to field questions. So please feel free to ask them in person because it is much better to hear from you. So without further ado, I'm going to hand over to Andrew, who will crack on.
Lovely, thank you so much, Vicky, and good morning, everyone. Good to see you all. So, as Vicky said, I'm Andrew Van Doorn. People call me Drew. I'm the Chief Executive of HACT, and I've been working not just at HACT, but throughout most of my career in the world of housing and homelessness, trying to kind of find a better way in which we can integrate housing, health, and social care services. It's a little bit of a personal mission and a personal passion of mine. As well as something that HACT does a lot of work on and feels quite passionate about as well. So just a bit about my background. So I started my career in housing many years ago when working in direct access hostels, working predominantly with men, not exclusively, who in those days, back in the 90s, early 90s, when people could just turn up at a door and if there was a bed, they got access to it. And I know that isn't necessarily the case everywhere now. And I also was both working in direct access as well as kind of delivering some resettlement support for people out of military prisons. And that's only because I was working in Colchester, and that's where the military prison is. And it's one of those things where it wasn't wholly planned. It was more the fact that actually we had quite a lot of people that would come to the night shelter in Colchester who were from the military prison. So, you know, you spot these trends and you try and get things to be a little bit more systematic. And I think the thing that I recognized really early on in my career was that when working with people who experience homelessness, actually, particularly single people, and particularly the group that I was working with back in the 90s, it was actually mental health was the main presenting issue, and that homelessness was a result of a significant amount of past trauma that often went unresolved, that resulted in a whole range of behaviours where people would be serially excluded from services. And there were very few organisations where actually there was an open door. And I worked in one of them. There was local day centre provision, but also the other open door at the local area was the NHS, particularly at the A&E department. Less so potentially around GPs. That was a slightly harder nut to crack. And throughout my career, that kind of how do we really bring together health and housing and health and homelessness was quite clear to me that actually, if we're going to address homelessness, then we've got to address the underlying mental health challenges that people experience. And I know that actually when we think about kind of health, homelessness and health, we're not just thinking about mental health, we're also thinking about physical health as well, because there's a significant amount of kind of a lack of access to good physical health services for people. I kind of took all of that forward with me when I worked at National Homeless Alliance, which became Homeless Link, when I worked in the Department of Health for a couple of years as the mental health and housing lead, and then subsequently since the work I've been doing at HACT, which is kind of really trying to integrate that agenda between housing and health. And it's one of those agendas that's really quite challenging. It's one of those things where, you know, we know that we all work with the same folk, and that in housing and in homelessness, that actually there's a lot that we can and need to do that helps people to kind of get access to better healthcare services. But it's also one of those agendas that feels it's quite intractable in some respects, that actually we spend a lot of time trying to make an imperfect system work. And from the perspective of housing and homelessness, we often reflect that every time we think we've got our heads around what the NHS is doing and how it's kind of delivering, it kind of changes again. And it certainly feels that way at the moment. So what I'm going to do over the next kind of 15 minutes is just really unpack a little bit about what's changing. I'm not going to focus in massively, actually, on lots of detail about homelessness and health. And I'm kind of assuming that as a group of people, you're here today because you understand that. And it's something that's really important to you. What I want to do is just help you understand what's changing in the NHS, who are the new kind of kids on the block in some respects, and how the integrated care systems are emerging as a way to help you start to think about how you might engage with that and where some of the opportunities are. Because I think something that I've witnessed over the last 2.5 years is that with the kind of the pandemic and with the amazing work that was done to get everyone in, there's been a lot of kind of outcomes from that. One of the things that feels quite live at the moment in the NHS is a kind of a new understanding and a new appreciation of health inequalities and issues around health equity and health inclusion. And it's a conversation that many people are now having rather than a few people are having, and that marks it out as quite different. So I think there are opportunities for us to be thinking about how we have different conversations and how we start to plan for a different set of kind of responses and services that really meet the needs of people who experience homeless, both single people and families as well. As I go through this, I'm going to be really mindful of the language I use, and I'm conscious that I'm speaking predominantly to a group of people who probably don't understand the ins and outs of the NHS. And in both the world of housing and in the world of homelessness and in the world of social care and in the world of health, there's a lot of jargon that we use. There's a lot of three-letter acronyms. In fact, one of the three-letter acronym which we all use, which we understand, is NHS. We all know what that means. But there's a lot of stuff that goes on. There's a lot of ways in which we talk about things that actually feels quite exclusionary in some respects. So I'm going to be mindful about the language I use. If, however, I start using stuff and I start slipping into things and you don't really understand it, can you just stick it in the chat box and we'll pick it up? And then when we're having a conversation later, if everyone can be mindful of language, I think that just really helps us when we have these conversations, because sometimes we need to just understand better what we mean by things. And if we're just mindful of the language we use, it just helps us to have that conversation, if that's okay. So I'm going to share some slides, and I'm going to say the other thing is this is my perspective of what's changing. I think the other thing everyone needs to realise about this thing we call the NHS is that the NHS doesn't have one perspective. There are lots and lots of different perspectives about how healthcare is delivered and what matters. And so I'm offering you my perspective as a non-exec director, as a leader in housing, and also someone who's spent a lot of time trying to work out what actually matters in this space. So if others have got other perspectives, then please bring them to the table, because they're very valid. And one of the we run lots of programs with people about helping them understand the NHS, and that's the first thing we say to people, is that you're going to spend time thinking about the NHS, and what you're going to learn is that there's not one view. There's lots of views. And there's lots of different people, because the NHS is a significantly huge beast. It's not one organisation, it's 9,000 organisations all working under a common purpose and a common brand called the NHS. And there's lots of different professionals, lots of different clinical people, non-clinical people, strategists, people who sort of, in lots of different services all over the country. So so this is how I view it, and hopefully you'll find that helpful and useful. So I'm going to share my screen. Excellent, that worked, good. So I want to have a think about kind of what's changing. I'm going to talk about integrated care systems, because that's the kind of organising unit, if I can put it that way, that the NHS and their partners in social care, and hopefully their partners in the voluntary and community sector and housing and homelessness spaces, are beginning to kind of work together at a place, at a geographical level. And they're called integrated care systems. They used to be called STPs, Sustainability and Transformation Partnerships. And they've all kind of moved forward now into these things called integrated care systems. I can tell you a bit about what they are, how they are kind of stacked up, what sits within them, and kind of what they do. So first thing to say is there's 42 footprints, so 42 geographical areas that are making up an ICS. Each has a chair, a CEO, and a chair of what is called the Integrated Care Board. So this is where some of the language starts to get a bit tricky. So the Integrated Care System is like the place, it's that big geography, and the Integrated Care Board is the bit of the Integrated Care System that's charged with purchasing and paying for and planning for healthcare services and for more integrated services. So integrated care systems bring together the CCGs. Now, as of the 1st of July, there will no longer be any CCGs, that's clinical commissioning groups. They will cease to exist from the 1st of July, and they will become the Integrated Care Board. But they also have other partners. Local government's a really critical partner to this. Invariably, when we think about local government's role in the integrated care system, it's either at a corporate level or it's at the social care authority level. There are examples where the housing, where kind of the perspectives of housing are within the ICS, but that's not necessarily the case. And there's lots of different examples where actually it's mostly the social care authority. And then the other part, and the ICS can be involved lots of other partners as well. So housing, homelessness services, voluntary and community sector, private sector, employers, whole range of people who might want to have to kind of work together to kind of improve health outcomes for a population. So you've got the Integrated Care Board, which is the commissioning, is the formal bit, and that's the bit that starts from the 1st of April. And then we've got the Integrated Care Partnership, and the partnership is kind of it's what it says on the tin. It's just the basic partnership that sits there to kind of help inform and create the forward-looking strategy. The actual statutory responsibility for the strategy sits with the ICB, but the ICP is there to kind of really help design it and drive it forward, because it's meant to be a partnership. And the ICSs are not new. They've been around for some years now. They actually predate COVID period. So they kind of moved forward from the STPs into these things called ICSs. I think the other thing to say is that most of there are relationships within these kind of 42 areas that have been there for a long time. So people have been working for a long time in many different guises, under many different types of labels, in trying to kind of plan for good healthcare systems and services and social care systems and services at a local level. So in some respects, some of this feels quite new, but for many people, it doesn't feel that new. It feels like these are building on relationships that have been there for a long time. The aim is to drive that collaboration. It's really important, but also for the NHS, this will be no surprise here, really thinking about finance, quality and health inequity. And I'll say something about inequalities and inequity later. The ICS has a responsibility for managing what we call the performance of the system. So in the NHS, performance is kind of driven, it's a very top-down performance culture. So the NHS England and NHS Improvement, they kind of define the priorities as agreed with the Secretary of State, and then that is driven through the system. And therefore it's at the system level which is the ICS, where we're beginning to see kind of the conversations around performance. And in performance terms, that is things like, you know, how the 4-hour wait in A&E, cancer targets that sit around cancer and diagnosis and referral to treatment. There's a whole range of targets that the NHS has, and it's had for some time now, actually. So that performance is actually driven at that level. And then finally, whilst we've got these 42 footprints, what we also have is in the NHS are some very specialist services, and they might actually be services delivered across a whole broad range of those footprints. I'll give you an example. So in mental health services, we have what we call forensic services, and they're services for people who have been sectioned under certain sections with regards to criminal behaviour. And they might be in secure care, and hopefully in the future they'll be released into the community and in community kind of based services. But those kinds of forensic services for mental health are not organised at the ICS level, they're organised at multiple ICS levels. And that's really important to recognise that, you know, where there's very specialist services, it takes more than one integrated care system to work together. So there's 4 key objectives of the integrated care system. The first one is about improving outcomes in population health and health care. And I'll say something in a moment about population health. The second objective is around preventing ill health and tackling health inequalities in outcome, experience and access. And this is really important. And as I said, it's kind of one of those conversations which feels very live at the moment. And there's a whole number of people who have had a rather rude awakening over the COVID period about the levels of health inequalities in our communities. For many of us sitting there in housing and homelessness, we've known this for a long, long time. Sadly, many people in the NHS haven't really had that level of awareness about what drives poor health outcomes from a health inequality perspective. So it's a very new set of kind of thinking and collaboration going on in that space. The third one is about enhancing productivity and value for money. You'd expect to see that as a key role for the ICS. And the fourth one, which is a really interesting one, is about supporting broader economic and social development. And for a long time, the NHS has not really been a key actor in that space. Well, I'd say it's not been a key actor. It has always been an actor in this space. It's not been explicit. And therefore, the ICS is meant to be working with partners locally around social and economic development. And we know full well that where there is that in there you will see things like you could see things like improving employment and access to employment for people. You could see stuff around housing in there. You could see stuff around important social development that actually has an impact on people, actually could prevent people from experiencing homelessness. So it's a bit of an unknown fourth objective at the moment, but it's and what it will actually do. But it's something to certainly to watch. And it's the other interesting thing is in that space, you often get the social value conversation in the NHS starting to emerge as well. So let me just pause about population health management, because this is a really important kind of concept that the NHS and their partners in the integrated care systems are beginning to kind of really grapple with. And there's and we use this flower diagram to kind of help people think about it. So first of all, and then actually, so the flower diagram it used to be 3, and now it's 5. And the 3 in the blue were the originating ones. So the idea looking at enhancing experience of care, improving the health and well-being of the whole population, and then reducing per capita costs of healthcare and improve productivity. The idea is that if we look at a whole population and we start to think about how do we provide different interventions at different times for the whole population, and can we prevent ill health in the future, bearing in mind that many people feel that the NHS is basically an illness service, it is about trying to get people to think differently about kind of, if we were to think from a population perspective, what might we be doing differently? And if you think about homelessness, if you think about some of the research that people like Susan Fitzpatrick have been doing for many, many years now up in Glasgow, that looking at kind of the life course of a single homeless person in particular. And what you can see is that there are we kind of know when at different ages, the kind of things that happen for folk that end up in someone being a rough sleeper in their 30s. And actually a population health management approach would start to intervene in a different way in those trigger points that are on. And so there's a real kind of preventative aspect to that. The other bit of here, so therefore, is the health and care inequalities. That's a really important new bit. And the other bit, which is quite new for the NHS around population health management, is about workforce. And I think that why that's new is that actually as an employer, NHS organisations, the organisation that I'm on the board of employs 8,500 people in 3 boroughs in northwest London. And if we can get it right for our people in the NHS, if we can be as concerned about their health and well-being as we are about the health and well-being of the people coming through the doors, then we will have a huge impact on population health. So we should be in the NHS thinking not just about kind of health and well-being for our workforce, but also their housing and whether they're under housing stress, and also whether they have access to all the things they need to be able to sustain their home. And we're having a conversation in our sector, as we are in our community at the moment, around cost of living increase and that whole crisis. Actually, if our people delivering health and care services are suffering because of the cost of living crisis, and their homes are at risk because of that, and we can prevent their homelessness, then we should be paying attention to it from a population health management perspective. But population health management is also a bit of a discipline as well. So it's not just a set of concepts, it's a kind of a way of thinking, a way of kind of crunching data and thinking about things. And in this space, what we think about is cohorts of people going through their life course, actually. And can we start to think about, do we have the right data? Do we understand our population? How do we design services that intervene at the right time in the right place? And then how do we know that they're effective as well? So there's a kind of it's not just a kind of set of concepts, it's a way of then planning for services. So I'm going to show you a little video just about the ICS. It's not that long, it's about 5 minutes.
Big changes are taking place across the health and care system. What does this mean for the organisations that make up the NHS? How will they collaborate with other parts of the system? And what will these changes mean for you and me? When the NHS was set up, it focused on treating single conditions or illnesses. Since then, our health and care needs have changed. More of us are living longer, and many have multiple conditions that require regular, ongoing care. However, this hasn't been reflected in the NHS's structure, a patchwork of organisations that often work independently from one another. Navigating this can be confusing and can have a negative impact on our experience of care. So, for some years now, health and care staff and leaders have been working to bring organisations closer together to better meet our needs by working in a joined-up way. Primary and secondary care, social care, mental health, and community health services have been seeking to partner with each other in different ways. At a very local level, GP surgeries have been coming together to form primary care networks, groups of practices working together across areas called neighbourhoods. By sharing resources and working closely together with other local people and services, they can provide a wider range of services than a single GP surgery. Health and care organisations have also been working together across larger areas called places, often covering the same area as a local authority, where large parts of the NHS budget are spent. Here, local government, charities, residents, and NHS partners can work together to understand and meet local health needs. But previous laws have prevented services becoming even more joined up. The 2022 Health and Care Act aims to change this and make it easier for organisations to work together. But what do these changes look like? Organisations are now coming together across even larger areas to form integrated care systems, partnerships of health and care organisations that plan and pay for health and care services. There are around 40 integrated care systems across England, and although they've existed for some time, the Health and Care Act gives them legal status, as well as new powers and responsibilities. Integrated care systems are made up of two parts: integrated care boards and integrated care partnerships. Integrated care boards decide how the NHS budget for their area is spent and develop a plan to improve people's health, deliver higher quality care, and better value for money. Integrated care partnerships bring the NHS together with other key partners, like local authorities, to develop a strategy to enable the integrated care system to improve health and well-being in its area. NHS trusts are also coming together to form provider collaboratives, new partnerships that can bring together providers such as hospitals, mental health services, and community services. So how are these new structures funded? Integrated care systems get most of their money from NHS England, which is the national body for the NHS in England, and sets the operational priorities for the health system. It's responsible for the health services you and I access day to day, which are inspected and regulated by the Independent Care Quality Commission. The Department of Health and Social Care sets out what the NHS is expected to deliver for the money it gets from the government, which comes from our taxes. It also holds budgets for some of the other areas that have an impact on our well-being, like public health. Throughout these new structures, local authorities play a key role. They receive money locally and from national government, which goes towards funding a range of services that support our well-being and prevent ill health. So, what does this all mean in practice? The Health and Care Act has put in place a legal framework that enables services to work more closely together, so it's easier for you and I to receive the care we need when and where we need it. For these changes to succeed, staff and local leaders will have to work with one another differently, alongside key partners in local government, the voluntary sector, and communities themselves. Of course, services face other challenges like workforce shortages, growing waiting lists, and the impact of the COVID-19 pandemic. While the new structures won't fix all these issues, by enabling services to work more closely together and join up services for patients, it's hoped that the health and care system will be better able to meet our changing health and care needs in the future. Find out more about how the health and care system is changing at www.kingsfund.org.uk/explain.
Great. So that's just a kind of a really, I thought, a quite helpful video, and it's on the King's Fund website. If you want to point any of your colleagues towards it, I think it's a really good description, and it provides enough confusion as well about, because it still isn't a very straight. It still doesn't feel very straightforward. What I'm going to do in the next few slides, I'll put them into the pack so that when we distribute it, you've got some more detail. I'm not going to dwell on this, but I'll point out some really key issues. So just thinking about the language that was used in that video. Neighbourhoods. So for the NHS, neighbourhoods is a language we now use around what we call primary care networks. And primary care networks are networks of primary care providers. They are not GPs. And the GP system really wants to stress this. This is not just GPs. This is all of the professionals that you need and the partnerships you need at a neighbourhood level to be able to deliver good primary care. So that's nurses, that's social prescribing, that's community pharmacy, community paramedics, mental health support workers, a whole range of people, OTs, nurses, we could go on. There's a lot of people that work at that primary care level. It's about providing a more kind of integrated approach at that neighbourhood level. Primary care networks, 30 to 50 population. And they're all in place now. Integrated care, the integrated care place-based partnership, and I'm sorry, it's a really horrible word. It's a really horrible title. Basically, that's what we now call the place level. So that's kind of roughly local authority level. It's roughly social care authority level as well, rather than kind of in where you've got two-tier authorities. It's mostly the social care authority level, but not necessarily. So it's about trying to organise kind of healthcare and social care and integrated services at a kind of a place level. And then you've got your integrated care system, as we've talked about up to about 2 million. And then you've got the integrated care boards coming and the partnerships coming into play as of July. So that's the building blocks that we now have. And there's a little bit in here about kind of how they regulated, where does commissioning sit, who are the providers, just to kind of help you think about who are the people, who are the organizations now that we see there, and how and who are the regulators that sit behind this new system. And it's still very much the traditional regulators around care, the CQC, the Care Quality Commission, and also NHS Improvement being kind of the key regulator for NHS providers. I think the other thing to say is that the video recognised that that we've got these things called provider collaboratives, and that's collaboratives of people who provide healthcare and social care services happening at different levels, but also the idea that you may not be able to get all things done at this big ICS level. So therefore the smaller delivery units are really important. And in there, we might take a pathway approach. We might look at things at a different level and look at how do we start to integrate people, integrate services together. And in there, we expect to see quite a lot of variation as well. Things that just respond to local issues, or and even when we say that, a local issue, for example, where I sit in northwest London, what goes on in Harrow and what goes on in Westminster can sometimes be entirely different things. So let's just spend a little moment kind of, just recognizing this isn't all sorted, folks. This is kind of all emerging. This is, whenever someone says to you in the NHS, we've got it sorted, full well there's a new reform about to happen. And so there's still lots of questions that are here floating around. Some of them are more explicit than others, but there is still a question about whether or not those 42 footprints are optimal. Does it really work at that level? We'll find out. There's questions about how will that transition from CCGs to ICBs work? Will that be seamless, or are there lots of new relationships that need to be built, new people are kind of in that space? How will the collaboratives work? And that's the collaboratives of the main NHS providers, predominantly, really, when we're honest about it, but actually they're supposed to be working with other folk. And where we see, for example, the mental health collaborative in Sussex, for example, one of their work streams is on homelessness. So it's kind of, you expect to see different relationships forming there. How do we actually really bring together all of this integrated environment? Because we've been talking about it for a long time, and it's something we all want to do, but we probably struggle with that quite a lot all the time. How do we cross both those kind of organizational and professional boundaries? How do we really kind of have the expertise and the skills and the leadership to be able to be integrated and be collaborative? And actually, does it feel integrated from the experience of people who use services? And often the answer to that is no, it doesn't. So still lots there. The whole thing about seats at the table is something that we have a lot in housing and in homelessness. I mean, there's lots of tables we could be seated around, and where are they? Are they having the right conversations, and why do we want to be there? And how do we best play a role in that? How do we make sure that all of this does work for people who are most excluded and furthest away? And people experience homelessness certainly in that group, that inclusion health group, because actually, our history tells us that we haven't really got it right for many people, and as a result, their healthcare has got worse, and their access to services has been significantly deteriorating. And then finally, issues around workforce issues, digital transformation. These are big issues in the NHS at the moment, and they occupy quite a lot of people's minds as well. We've got two final slides. I wanted to bring to your awareness the concepts of health inequalities that are currently coming out of NHS England, and it's all around what we call Core 20+5. What this means is that in delivering that strategic objective around tackling health inequalities from the ICS, it's about a way of prioritising. Who are we talking about, and where do we look? So the core 20 bit of the target population is the most deprived 20% of the population. So that's using the indices of multiple deprivation. We know where those communities are. We know and we know down to the lower super output area level. So we know down to roughly around 1,000 households of which areas are most deprived. So it's about focusing effort and interest into those areas. The +5 is, the plus bit of it is those 20% plus other groups. And what's really interesting, if you look on the top right-hand side of that, they talk there about the kind of the inclusion health groups, and that's where I think you might expect to start to see homelessness featuring. because as a kind of a plus bit, and then the 5 are the 5 conditions that the NHS has kind of prioritised as needing significant focus with regards to health inequalities. So maternity, because we know that actually people from poor backgrounds have actually some of the worst maternity outcomes, both with regards to baby infant mortality and also mother mortality as well, and just the experience of maternity care. We know that for severe mental illness, a significant issue that we need to address, chronic respiratory disease, early diagnosis of cancer, and then hypertension as well. Final slide is kind of, so where will homelessness sit in this new landscape? And I think, first of all, I'm going to say I really don't know the answer to that. I think it might sit in a number of places, and actually if you want to find out, you're going to have to engage locally to find out the answer to that. So in policy and strategy, you're going to see it in you should see it in population health, you should see it around health inequalities and health inclusion, but also health equity. And in the NHS, health equity is an interesting concept. It's a nuance of health inequalities, but it's predominantly around access. ICS is going to be delivering their 5-year plans, and they're all going to do that for the beginning of next year. So we would want to see it there as well. And then actually workforce. So I have to put workforce there because there is a big issue in the NHS at the moment, which is we just don't have enough people in the right roles to do the job. So are there creative thinking we can do around bringing, a workforce in it, or addressing workforce in a different way? So we're looking at multidisciplinary teams, actually having specialist housing and homelessness workers within multidisciplinary teams is something that's beginning to happen. And actually we can develop the workforce, because in some respects, it's going to take us a long time to kind of train doctors and nurses, but actually we need more than doctors and nurses to deliver good health outcomes. From a delivery perspective, we need to look at the primary care networks, social prescribing and mental health will sit there. Some of it will sit there. We need to look at the place-based plans, because that's the kind of the main organising unit for local government as well, and collaboration. How do we look at different pathways? So how people experience services in the NHS is called a pathway. How do we start to reform those pathways so people who experience homelessness get better access and better outcome? The provider collaboratives are going to be really important, and some of them are already starting to look at homelessness as a priority. The forever issue of integrating drug and alcohol services with health services, it is a huge issue everywhere. I don't have a solution for you, but many people don't have a solution, but we know that that's a really important interaction for people who experience homelessness. And then finally, the community mental health services. There is a huge amount of transformation going on for acute mental health services that work in the community, and there's resources on the table, and actually in there it should be a very significant conversation around homelessness and around how we ensure that nobody, particularly with severe mental illness, is discharged onto the street or into the worst forms of housing. So they're my thoughts on what's going on, and happy now to have a bit of a conversation, take some questions and take your thoughts on that as well.
Thank you, Andrew. That was really, Drew, sorry, that was really interesting and a lot to take on board. Quite confusing. But it seems that now could be an ideal opportunity for housing association to sort of get a seat round the table, as you put it. Do you think this is the ideal time, would you say?
I think so. Yes, but my caution in that space is actually what table do you want to be round?
Yeah.
I think often there's a kind of a thing, let's all be around the ICS table or the ICB table. It's like, no, I don't think you want to be there. Actually, I think, unless you're a masochist and you kind of want to sit in those kind of conversations, which can sometimes be slightly turgid, you want to be around the tables where strategy is being created and thought about. But actually, you want to be at place and local and PCN tables. That's the kind of conversation you want to have. Because if we think about homeless, if we think about homelessness, how people experience homelessness, get access to good healthcare. Predominantly the route is going to be either through primary care, as it always is, or might be direct through into kind of specialist mental health services. So and they're going to be organised at that level, place and neighbourhood level, less so at the ICB level. But the other thing is, how do we talk to providers in this space as providers? We've spent a lot of time in housing. thinking that the commissioner rules the roost, and actually in the NHS the commissioner doesn't rule the roost, the providers rule the roost. Most NHS money is spent at the front line, and it's at that front line where you want to have those conversations.
Does anyone have any burning questions that they'd like to ask? It'd be good to hear from people listening in what their thoughts are on all this. Any sort of experiences that they've had to date that they'd like to share that could be useful. Here's a question from Carolyn Mann. Should housing associations wait to be invited to the table?
No. Because if you're going to wait to be invited to a table, you're never going to get invited. It's my. I don't think as a housing sector we've ever got progress by waiting around meekly for someone to invite us to something. We often, when we get our big boots and we put them through the door and go, "Hello, we're here. We've got something to offer." And I think that's the really important thing about this. Is so I joke about it, but actually, there is a lot of change going on, and at moments of change, most big sectors and systems kind of inward look. At that moment of change, they don't outward look. And actually, I think it's actually, we are as a sector much more nimble. We're much more creative in some respects, and we just need to go and spot those opportunities. But when we get to the table, what do we do is the question. And I think partly one thing I'd say is we listen carefully to what's being talked about, because in some respects sometimes we misfire when we think we've got an answer to a problem and it's not really a problem. I think the other thing is actually advocate. I mean, the thing that we have, the insight that we have access to by working with people day in, day out, and working in communities day in, day out is really valuable to people trying to think about how they're different in that kind of integrated environment. And we can bring all of that insight to the table, and we can help people think slightly differently about how they might do things. I think if we are both offering insight and offering really creative problem solving and putting some of our resources to play, that's when I think we'll get some really exciting, creative, different solutions.
So Terry, I think Terry is from Nightstock Communities, and that is a charity, is that right, Terry? Approached, and local authorities still waiting for a response. And then Dave Barrow of Nottingham Community Housing Association, are there any figures available on how many homeless people are taking up hospital beds due to the lack of homeless and specialist services? Would be interesting to know.
That would be interesting to know. I don't think there is a national picture. I think there might be in some places a local picture. I think if you want to understand the question of people who are stranded in very expensive NHS beds because of a lack of access to housing and housing support, your trusts will know the answer to that, because it's a big issue. Discharge is a massive issue at the moment. The mental health trusts, I think, are very on top of this at the moment with regards to understanding what's going on. They don't necessarily have the solution, but they certainly know what the issue is. The acute trusts less so, because the acute trusts are a lot of their focus is actually more on older people being stranded than people experience homelessness. But I tell you what, and if you go and talk to any senior manager or senior clinicians in an A&E department, they would certainly be able to tell you how many folk who experience homelessness walk up through their doors every day. And they will certainly be able to tell you how what the issues are for them as well. So I think the intelligence is there. It's not always collated in the most helpful way.
Carolyn says, Finland has a good approach to homelessness. Do we have enough available properties to take this approach nationally? I guess supply must be a consideration. Are you talking about housing first, potentially? I'm not sure.
Yeah, so the Northern Scandinavian countries have a really, they do have a very excellent approach to homelessness. They have a very different welfare system than we do, and a very different healthcare system than we do. They also have, in Norway, for example, they even have kind of a bank where if you're homeless, you get a property bought for you. So there's certainly things we can learn from them, and but there's also certain things that we need to make it relevant to how our system works in this as well. But yeah, I'm a great fan of learning from all over the place. But I would also just be slightly cautious about kind of some of the claims in this space. So Housing First is really interesting. Housing First is really good. It's really excellent. It delivers really stable accommodation outcomes. The evidence doesn't suggest it delivers stable therapeutic outcomes, actually, or long-term therapeutic outcomes. So you know, yeah, we should be evidence-led, but we should also make sure that we're improving the evidence as we go as well.
Are there any? Oh, hang on, we've got another quote. So Dave Burrell from Nottingham Community Housing Association says in Leicester, the NHS/local authority have a hospital re-enablement team to find alternative accommodation for patients who are ready for discharge. Also, there is a GP service for the homeless of the city, and also a homeless mental health team. They are quite already joined. I was reading about Leicester recently, and they are quite joined up, aren't they, in their sort of homelessness approach. They have a homelessness charter, I think it is, in Leicester. I know that NCHA are involved in that.
Yeah, I mean, Leicester is Leicester is a good example, but also if you look across most of the urban, the cities, most of the cities do have and have had in the past significant kind of programs where people have tried to deliver services differently to people who experience homelessness. And, you know, the whole, you know, thinking back to the creation of the Homeless Mentally Ill Initiative, not necessarily a nice title, but you know, that was all created in the 1990s and in London, and, you know, recognizing that actually there needs to be a very different response from the mental health system to people who experience homelessness. And so, yeah, so we see lots of kind of stuff like that. We've got pathways, we see lots of, we see some specialist nurses. I would also say that having kind of worked over many years with particularly with clinical staff, so doctors and nurses and others who specialize in homelessness, they experience it can be quite an isolating experience for them as well professionally, because they're unique and marvelous people that want to specialize in that, but there's not many of them. And sadly, not always their peers view their work to be the thing that they think progresses their career. And so I would say if you've got local clinical specialists in your area, go and love them, go and be there, you know, because it can be a massively isolating experience for them. Working in the NHS system, you know, go love them and help them be the best advocates that they can be as well.
Yeah, I think I had a conversation with For Housing, and they were, you know, they had that sort of relationship with I think there was a GP homelessness specialist in Salford Primary Care Trust, and, you know, they were there to sort of say, well, how can we help, what can we do together? I think that's, you know, that really worked for them to get the service that they've introduced for hospital discharge off the ground. Yeah. Forming that relationship. I think Rebecca Slack has a question.
Hi,
feel free to fire away, Rebecca.
Thanks. It was just, I work at the National Housing Federation, and I know we've got a meeting in the diary, Drew, but we've just, as part of our overall business strategy, we've got housing and health integration as one of the priorities in there. And what we want to do is we want to approach the ICB chairs and chief execs to give them some sort of collective national evidence about the social economic value of housing associations and what they're doing and what they can achieve around health and well-being. But what we also were thinking of asking them is what they would want from us on a national level, what sort of data that they would find useful. So it's about ensuring that it's part of that 5-year plan that Drew talked about, but also how they can engage with housing associations and housing providers in those 42 areas. So I think in some areas, like Drew said, there's ICS already set up. It's quite well established, but there might be some areas across the country where it's not so good and where we might be able to help facilitate a bit of that conversation. So it's just to let people know we're kind of looking at where the Fed can have an impact, but where we can work with partners on that.
Are you sort of feeding out to housing associations in sort of members to sort of get their input?
Yeah, I mean, we've got quite a few examples, but we're going to start collecting that over the summer. We're also doing a piece of research around the impact of supported housing on homeless prevention, but also health and wellbeing outcomes. So that's going to be completed December. So that was a member-led piece of research. So we're trying to get what we can and bring it together sort of over the next few months to influence that. But yeah, we are reaching out to members.
I think it's an interesting time, isn't it? Because I think for housing and homelessness providers, what the NHS might potentially want from us goes way beyond our care and support specialism. It's all the work that we do in communities, it's all the community investment work that we do, it's all the work that we do in preventing tenancy failure, in helping people to thrive in communities, and as well as all of the homelessness service, all of those things. And I think also for housing associations, it's about how are we good partners to each other and to the broader homelessness sector as well, because because actually from an NHS perspective, you often hear this from very senior leaders in the NHS, they kind of we confuse them. We're not clear to people about who we are and what we do. They don't actually see the breadth and the depth of the work that we do. And actually in some respects they want us to help them kind of navigate to the right places. And if you're an NHS trust working across 3 local authorities, and then across those 3 local authorities you've got 50 housing providers and 10 different homelessness agencies, you're not going to engage with all of them. So what can we do to kind of make ourselves more intelligible in some respects to others and help them see us in the way that we see ourselves? And then I also think that if we start thinking about what's coming down the track in October, with increasing kind of fuel costs and things like that, we need to look really carefully into our own operation as housing organisations about making sure that we're really supporting people not to prevent future homelessness, because I think that's a real risk. And having that conversation about how do we help people under significant distress to access good health services as well as access good housing and homelessness prevention services is something that we need to start talking about now. Because we do it, but is it really working effectively enough for what's about to happen?
Just looking at the chat again, Martin Hender says, in Ipswich, our Housing First is part funded by CCG, ICS, and we work closely with local NHS health outreach to support physical health needs, which is really interesting. I haven't seen that before, with some good outcomes. Sorry, Martin, I don't know, I've got a list, but I don't know what organisation you're from.
Ipswich Borough Council.
Oh, okay.
Yeah.
So how did that partnership come about with
it was instigated by Health Outreach, really. They put a proposal together that they would dedicate team members to our Housing First tenants, and they would have a surgery on a Wednesday. So there was a lot of to and fro from the Housing First team to the Health Outreach team to get the consent from the tenants to be on board with this, which has been a great success. And the tenants have embraced it, and so have both parties of the partnership. It's been really, really good, and it's delivered a really good outcome, because they don't only look at physical health, they support within mental health as well, and to access substance misuse services as well. So it's been really good.
That's excellent.
I think there's a real opportunity to kind of inspire people with those kind of examples. There are lots of really good examples, and the stuff that's been going on for years and years and years in kind of making this a more integrated agenda that improves better outcomes for people who experience homelessness. And I think sometimes people when they're at like the ICS, ICB level, when they're planning healthcare services for a population of 2 million, sometimes people just need a good dose of inspiration about what they can do, what the possibility is, and what could make it work. So I think kind of how we promote those kinds of solutions to across the NHS is really important, because mostly people kind of don't always know what they can do and how they can be different. And then also who are the organisations that can support them to do that too.
We've got a raised hand, but I don't know your name because it just says iPhone. But so
I didn't actually mean to raise my hand.
Oh, okay.
Sorry, but I'm Sam. I'm from the health outreach team and the team that Martin was just talking about. So we are providing clinicians and clinic time to health screen all of the Housing First tenants.
And is there a housing association involved in terms of providing the properties or in any of the support element in Ipswich?
Martin
So
will explain.
we have currently 17 tenancies. Majority come from Ipswich Borough Council stock, and there's 2 housing associations that are on board, but only with 2 properties at the moment.
Yeah.
So yeah, majority is from our own stock.
Yeah, but good that you have some housing association involvement.
Yeah.
Yeah. Okay, I don't know, we're sort of approaching the end of the session, so unless anyone else has any burning questions to ask, we're probably going to wrap up. So yeah, thank you to Drew for that really helpful whistle-stop tour of all the reforms that have happened and what this could mean. I think previously was asked in the question in the chat if we'll be circulating the slides, which we will be, and also Drew's contact details. So yeah, I'll send those out by email. And yes, thank you very much to Drew for your insight and knowledge, which has been really valuable. And thanks all for coming, and look forward to seeing you at future workshops.
Lovely, thanks Vicky, thanks everyone.
Bye.